The speaker for this presentation is John Prowle.
Hello everybody, my name's John Prowle. I'm an intensivist and nephrologist from London in the UK. I'm joining you today from the Royal London Hospital. I'm at work. We've currently got about 150 COVID ICU patients in our hospital. And my talk today does revolve principally around our COVID ICU experience in the first wave of the pandemic and a lot of analysis we've done with regard to both ethnicity and AKI. And these are very preliminary results. They're thought-provoking. They ask as many questions as they answer. And I'm sure you'll want to contextualize this with your own experience and other publications after you've heard my presentation. Much of the first half of this talk is based on our recent publication in the BMJ Open, which I've given you the reference to here. So just to give you a bit of background, I work in a hospital system that serves most of the east side of London and the suburbs. It constitutes 6 university-associated hospitals, serves a population of over 2.6 million people, and it's one of the most ethnically diverse populations in the UK, and it contains some of the most socially deprived communities in the UK, as well as some much more wealthy communities. It also experienced some of the highest COVID-19 related mortality in the first wave of the pandemic, and therefore Barts Health and our associated university, Queen Mary, has been at the forefront of the clinical and scientific response to COVID-19 pandemic. And clearly within this, we wanted to assess the effect of COVID-19 on our diverse community. We're fortunate to have a very rich data set available from our electronic medical record, including demographics, comorbidity profiling, clinical and diagnosis-based criteria for frailty, which I won't go into too much in this presentation, a lot of pathology data, including data from primary care. And so the majority of these patients had pre-existing blood results, things like serum creatinine, which is clearly very important. And then we had information from our critical care data set about interventions and organ dysfunction. And so we're able to provide a very comprehensive and detailed overview of these patients and their outcomes. So our first study was called the ethical study, and we identified almost 2,000 emergency admissions to hospitals within our system with a positive COVID-19 viral swab, and that was through to the 13th of May 2020, which was the period which really fitted the first wave of the pandemic in the UK. A number of patients had missing ethnicity data, which we excluded from our primary analysis. Of course, a large number of patients had died, and that's very important to our analysis. But what you can see is that that we had a very significant number of patients from Asian and Black backgrounds, and only a minority from white backgrounds. I should also point out that when I'm saying Asian in the rest of this talk, in the UK, I'm principally referring to a South Asian population, people of Indian, Pakistani, and Bangladeshi descent, as opposed to an East Asian population who are actually categorized in the other ethnic group designation within the UK system. So for Asian, we should be talking about South Asian. And these are the hospitals that were included, a mixture of emergency COVID-19 response, teaching hospitals, and district general hospitals. So this is the timeline of patients with positive COVID swabs during the first wave of the pandemic. You can see that really by the time we completed our follow-up, we'd captured the majority of the picture of these patients. And then, of course, we were able to collect their ongoing mortality and blood results over the succeeding period of time till near the present. This is our detailed ethnic background. I won't take anything more than to emphasize diversity, and also to emphasize that in East London we have a very large Bangladeshi population, and amongst South Asians these are actually more socioeconomically deprived people from this background, and they're perhaps a slightly more recent immigrant population. So just to recapitulate, 60% of the population from a minority background, a large cohort of Asian, British Asian, patients and little high quality data on these patients, and a substantial amount of deprivation as measured by UK and national statistics for deprivation. This is based on patients' addresses and UK statistics on deprivation by postcode. So the total mortality in this hospitalized cohort was 28.7%. And the raw mortality is interesting, although deceptive. The mortality overall was highest in the white group and lowest in the Asian group. But of course, this is meaningless without considering the underlying characteristics of the patient groups. And here are the median ages of these populations. And you can see the white population was very significantly older than the other groups. And so when we did an age of sex adjusted hazard ratios for survival, in fact, being of Asian or black background was significantly associated with higher mortality than being of white background, because patients with white background at these ages were not just getting into hospital because presumably they weren't sick enough. And so this is an analysis stratified by ethnicity. And what you can see here is that Asian and black patients had a higher mortality early on, but there was a slight divergence later on with black patients perhaps experiencing a lower level of late mortality. This is adjusted to the median age and male sex. Now, as well as the differences in ages, there were also differences in the prevalence of comorbid diseases, in particular diabetes, hypertension, and chronic kidney disease, which are key associations of poor outcome in COVID-19 disease and key associations of kidney injury. And this heat map here really demonstrates the differential age profile of comorbidity by ethnicity. And because this is sort of complex multidimensional data, it's a little bit difficult to interpret. But basically what you can see here is that the non-white ethnic groups are developing much higher levels of diabetes, potentially hypertension in younger age groups, whereas things like frailty were more common in the white patients. And so perhaps older white patients were dying because of frailty and maybe treatment limitation, whereas older patients with ethnic minorities might have been dying more related to disease severity than their comorbidities. Biological characteristics of illness did seem to differ between the populations. Notably, the black group had a much higher incidence of acute kidney injury. We're going to focus on that later in the talk. They also had higher D-dimers and somewhat higher CRPs. And so there's obviously quite a degree of diversity within the response to illness, which may reflect some of the comorbidity background of these populations. People with ethnic minority backgrounds were more likely to be admitted to ICU, and they were more likely to receive mechanical ventilation, possibly reflecting they were sicker at a younger age group. Certainly they were not being denied access to critical care. There's one suggestion was that they may have had delayed presentation to hospital, and that could result in them presenting with more complications such as acute kidney injury. However, while there were some differences in their warning score, physiological scores on presentation to hospital, these weren't actually particularly clinically significant in terms of magnitude. And the number of days in ICU in hospital prior to admission to ICU didn't differ between the groups. We did multivariable analysis to adjust for a variety of confounding variables, and I'll present just a little bit of this. But what you can see is that even if we accounted for some measures of important comorbidities, age, sex, and social deprivation, Asian ethnicity was still associated with increased risk of death, but black ethnicity slightly fell below the 0.05 p-value significance level. So I'll move on to the AKI data here. So we've done a secondary analysis now, which hasn't yet been published, on the AKI data in our population. And we had to exclude patients with pre-existing end-stage kidney disease and those without sufficient renal function data. And then we had a population of about 1,800 patients. And then there were a certain number of patients, but actually only about a third who had no baseline creatinine. And they were still studied with an imputed baseline, but we also did a sensitivity analysis excluding them. So this is a bit busy, but here is the overall results in terms of early AKI. This is AKI occurring within the first 7 days of hospital admission. And we've got our ethnic groups across here. And overall, as I've suggested, that the percentages here work out slightly differently, but black patients are only 16% of the total population, but they form 21% of all of those with AKI, and they formed a large portion of those with more severe AKI over here compared to the white population, who formed 35% of the overall population, perhaps had more earlier AKI but less severe AKI, and weren't more represented in AKI overall. So small differences between the ethnic groups here, which we need to sort of interrogate more, because obviously there are age differences between these populations. Also, it's important to consider that different trajectories of AKI do exist, and these can have their effect on outcomes beyond the first 7 days, including late AKI, relapsing AKI, or recovered versus persistent AKI. And we've analysed these, additionally related to ethnicity, and perhaps we see slightly more persistent and late AKI in some of our ethnic groups. It's a little difficult to interpret, but it's a very interesting to look at these different patterns and their relationship to outcome. But overall, relatively consistent numbers between the different groups in proportion to their overall distribution in the population, but perhaps a slightly higher uptick of late AKI in the non-black groups. And it's slightly easier to see in this slide where we have the different ethnic groups, and what you principally see is perhaps there's slightly less recovered AKI in the Asian groups, and perhaps slightly more persistent AKI in the black group. But there's more data which really needed to tease this out. But the important thing is these different trajectories of AKI have very different effect on the outcomes. So going back to AKI itself, and this is early AKI, these are the different risk factors for early AKI studied in multivariable analysis. And the one thing I'd point out here is that black ethnicity was a risk factor for early AKI overall. However, CKD didn't cross a significant threshold in this analysis. But other instances, like, for instance, the HLH score, which is really related to the severity of inflammation in AKI, was significantly associated. So we've moved on now to the next slide, which is those with a known baseline. And there's a slight difference here. And so that black ethnicity has kind of gone back to being slightly non-significant, whereas with more accurate data about baseline chronic kidney disease is a significant predictor for AKI. And so this suggests to me that potentially black ethnicity is associated with AKI because of an association with underlying CKD when you capture that more precisely. So in this slide, we have survival by AKI stage. This is an unadjusted Kaplan-Meier plot, and you can see here that stage 2 and 3 actually have quite similar outcomes in an unadjusted Kaplan-Meier, and to some extent that's because you have to survive a certain amount of time to reach AKI stage 3, and some patients with AKI stage 2 die early before they ever have a chance to progress to that maximum stage. But overall, in the adjusted analysis, all forms of AKI are associated with less chance of survival. Similarly, AKI is associated with risk of ICU admission. And here we have, in particular, stage 3 AKI being strongly associated with ICU admission. Again, this is a chicken and egg situation, because obviously to receive renal replacement therapy, the vast majority of patients were in the ICU. And therefore, they had to be admitted to ICU in order to achieve AKI stage 3 by the criteria of having received renal replacement therapy. Notably, a younger age is actually a risk factor of coming into ICU. Older patients may have had treatment limitations on the ward if they had severe multimorbidity, which is a converse to the association with the risk of death or the risk of AKI. This is survival by AKI trajectory. So we've got here recovered AKI, that's AKI that had gone within the first 7 days. Persistent AKI, that was AKI that was still evident at 7 days, and therefore these patients would then meet the AKD, acute kidney disease criteria. relapsed AKI patients who had recovered but then had further episodes of AKI later, and then some patients with late AKI, no AKI within the first 7 days, but developing AKI later in their clinical course, which appeared to be associated with a relatively poor prognosis in addition, perhaps because that was part of a terminal decline in multi-organ failure. But a clear signal here that it's not just the severity of AKI, it's actually the persistence of AKI that's the clear thing. Obviously, this is in patients who've survived beyond 7 days in order to be able to make this assessment. In this analysis, once we've got out to this period of time, it's the AKI and its trajectory that's driving the outcome, and it's not related to ethnic background or many other of the baseline risk factors, including CKD. So to summarize, Black and ethnic minority patients admitted to Barts Health Hospital with COVID-19 disease were disproportionately younger than white patients. And this was by a massive difference in median age of 14 years in the Asian patients, which is a sort of actuarial order of magnitude in terms of risk of death. They were an increased age and sex-adjusted risk of death. And we couldn't account for all of these associations by COVID-19 or by comorbid disease or other baseline risk factors. They also had less severe frailty, and they were more likely to be admitted to the ICU and ventilated, certainly consumed much more hospital resources in terms of their illness. And perhaps these were patients who we would not have expected to die, who still did so. And what's the involvement of the AKI? Well, obviously AKI is part of the disease process, so it's very difficult to entangle causation from correlation and determine the direction of causality. And also the relationship with ethnicity is very difficult to disentangle. Both Black and Asian patients had a higher prevalence of known AKI risk factors at a younger age, particularly diabetes, chronic kidney disease, and hypertension. Black patients were independently at high risk of AKI, but this disappeared in favour of CKD when only patients with a known baseline creatinine were included. So I think that when you get more data in there, obviously associations for individual things become less significant. But actually, if you get more accurate data in there, that probably favours the fact that CKD is the underlying explanation in that population. Accounting for AKI didn't attenuate the early risk of death associated with Asian ethnicity, but it did some with that with Black ethnicity. And after accounting for AKI trajectory in AKI survivors, ethnicity was not a predictor of survival. And so to what extent AKI is mediating the risk of death associated with comorbidities and with ethnic background is something that's extremely difficult to disentangle. But to some extent, that's not necessarily a meaningful clinical question. What we should be aware of is that patients from minority backgrounds have a risk profile that puts them at higher risk of AKI. They present earlier but still have poor outcomes. And interventions aimed at reducing risk of AKI and improving outcomes for patients with AKI, you would feel to be highly appropriate to apply to these populations. So our interpretation finally would be Black and Asian patients in our community at increased risk of premature death in COVID-19 disease. They have a distinct pattern of comorbidities, younger age, including several AKI risk factors. AKI may play a role in mediating adverse outcomes in Black patients, but it's features less clear in those of Asian backgrounds. And really, the complex socioeconomic, potentially biological, cultural, political factors underlying these associations require urgent ongoing investigation in order to better improve our outcomes for our population. And I'll conclude there.